For kind words of introduction. As you described, now my area of interest is cornea keratoplasty and pediatric cataract. So now I hardly do DCR. In last 5 years of my tenure in AIMS Patna, I have only done 2 DCR. That is only of basically faculty relative and faculty close friend. So, but during my PG days and in other institute, I have done so many TCR. But the difference is that at that time, basically, anatomy was not so clear to, and so there was lot of bleeding, lot of complication, lot of failure also. But now it is more control. So, as you all know, sorry, just a moment. So lacrimal drainage system consists of main lacrimal gland, accessory lacrimal gland, upper and lower puncta, paired lacrimal canaliculi, lacrimal sac, and nasolacrimal duct. So coming to the main lacrimal gland, it's located in upper lateral tarsal aspect of globe and secrete tears through a series of duct which opens in superior fornix. And it has 2 parts, larger orbital part and a smaller palpebral part. And it is divided by the levator muscle. Orbital part is almond-shaped tubulo-acinar gland, larger and superior part located in the orbital fossa. And it is related to superiorly with periorbita, inferiorly with LPS, laterally lateral rectus, medially LPS. And anterior border is septum orbital, and posterior border is continuous with the palpebral part of the gland. Coming to the palpebral part, it is flattened horizontally. A smaller and inferior part lies over the levator and superior fornix, visible transconjunctivally. So, ducts of lacrimal gland pass through the palpebral gland. It is 10 to 12 in number. So, why it is important? If palpebral part is damaged, so lacrimal secretion is basically it becomes low or it may be absent. Coming to the accessory lacrimal gland, it is mainly 2 accessory lacrimal gland, gland of Croj. It is microscopic gland located in the subconjunctival tissue of fornices. It is around 40 to 42 in upper part and 6 to 8 in lower fornix. Gland of Wolfring, it is again microscopic gland. It is 2 to 5 in upper border of superior tarsus and 2 to 3 in lower border of inferior tarsus. It is and other rudimentary glands that can also secrete some aqueous part in caruncle, in plica, and infraorbital region. So basal secretion of tear is secreted by accessory gland, and reflex part is secreted by the main lacrimal gland. Coming to the puncta basically opening of 0.3 millimeter in diameter located in the medial aspect of upper and lower eyelid margin. And each punctum sits on top of the elevated mound known as papilla lacrimalis. Inferior punctum is slightly more temporal compared to superior puncta. The puncta are relatively avascular structure in comparison with the surrounding tissue, giving them a pale appearance which is accentuated with lateral traction of the eyelid. This pallor can be helpful in localizing the stenoid punctum. Coming to the canaliculi, canaliculi have an initial vertical orientation followed by horizontal and approx 90-degree angle. Canaliculi should be dilated at the junction to form the ampulla. Canaliculi pierce the lacrimal fossa before entering the lacrimal sac. That is why basically orbicularis muscle controls the drainage of the tear. In most individual, horizontal portion of canaliculi converge to form the common canaliculi. In others, it opens only around 10%. It may open separately. So, common canaliculi may dilate slightly, forming a sinus of Mayer at the junction of the sac. So, while probing or syringing, first orientation should be vertical, and then there should be lateral traction. Then one should go for syringing. Otherwise, there is chances of false passage formation. Similarly, again, while probing, especially one should go from the upper canaliculi. So, oblique entrance of the common canaliculus into the lacrimal sacs forms the valve of Rosenmuller, which prevents retrograde reflux of fluid from the sac into the canaliculi. An incomplete valve of Rosenmuller is observed clinically as air escaping from the lacrimal puncta when individual blows her nose. So, coming to the lacrimal sac sits in the lacrimal fossa, and it is bounded entirely by the frontal prosomaxilla bone, and that is called anterior lacrimal crest, and posteriorly by the thin lacrimal bone known as posterior lacrimal crest. Differing proportion of lacrimal bone and maxillary bone make the lacrimal fossa, and its dimension is approximately 16 mm high, 4 to 9 mm wide, and 2 mm deep. For endoscopic DCR, one should able to localize the lacrimal bone. So intranasally, its position is anterior to the uncinate process of the ethmoid bone. So first surgical tip is avoid injuring to the angular vein during a skin incision. Safest skin incision is over anterior lacrimal crest. How it will be basically localized? One should feel the inferior orbital margin, and then by going up, one can feel the anterior lacrimal crest. So, third surgical tip is one should restrict the bony window area between the anterior and posterior lacrimal crest. That is called lacrimal fossa. As going beyond it, especially downward, can open into the paranasal sinuses. So, what are the relations of lacrimal sac? Medially, there is periorbita and bone, arc of ethmoid sinuses, lateral skin orbital orbicularis oculi and lacrimal fossa, anterior, medial palpebral ligament and angular vein, posterior lacrimal fossa and muscle. So, what are the parts of lacrimal sac? It is divided into.
Dr. Amit, we are running short of time.
Yes. Okay. It is divided into fundus and body. Fundus is 3.5 mm above the superior portion of medial canthal tendon, and body is 10 mm below the fundus. So, these are the relation. So, why it is important to know the superficial head and deep head of the orbicularis oculi? It encompasses the medial canthal tendon. So, basically, when you are cutting the orbicularis muscle, you will cut the tendon. So, there should be blunt separation. So, surgical tip number 4 is separate the orbicularis muscle using blunt dissector or bait gauge piece, and never cut them to avoid bleeding and loss of lacrimal function. Last one is the nasolacrimal duct. It is again divided into two parts: intraosseous part and a membranous part. Intraosseous part is longer compared to the membranous part. There are many valves, but main important valve is Rosenmuller valve, that is between canaliculi and sac, and the Hasner valve between the inferior meatus and the lower part of the nasolacrimal duct. The valve of Hasner is important as it opens opening in the nasolacrimal duct, and it is imperforate in around 70% of newborn, but there is a spontaneous opening in 6 to 12 months. So, it is not that before 6 months one should go for syringing and probing. First, one should wait, or one should go for criccular massage. Conservative management should be done. So, vascular supply, it is by lacrimal artery, sensory supply by lacrimal nerve, and So my take-home message is with proper understanding of anatomy of lacrimal drainage system and the anatomical landmark, success rate of lacrimal surgery can be maximized. For a skin incision, trace anterior lacrimal crest by palpating upward from the inferior orbital margin. Injury to angular vein can be avoided by making a skin incision on anterior lacrimal crest. Orbicularis oculi is essential for lacrimal pump function. Therefore, the fiber must be separated by blunt dissection, never cut. In infants, with watering imperforate valve of Hasner may be the cause. Chances of a spontaneous recanalization after conservative management is high. Thank you very much for
Thank you.
patient here.
Thank you, Amit, Dr.